what is essentially when in the ER, you are go to the ER, there will be patients who will be there will be some patient in the ER. We need to see if the triage criteria have been applied to these patients or not, or on what basis it has been done. And obviously, you will see a lot of this in this presentation today. Try and use what if scenarios. We can always ask the nursing staff, the medical staff, the various scenarios and see if they are well versed in the various triage criteria. Because as the mandate is, it's not just sufficient if it is documented. The key thing is it has to be implemented. The next aspect is again, in a way, there is no new major change, but again, one change which reflects entire standards is essentially the word BLS and ACLS have been removed. We no longer use the word BLS and ACLS. They have been replaced with the words basic cardiopulmonary resuscitation, advanced cardiopulmonary resuscitation, adult pediatric or neonatal. That's the new thing. Here again, I feel this is a good way of trying to find out what is happening. Again, using a what if scenario. Again, please note, you are free to use whatever you think you deem fit. These are just some guidelines, some suggestions that you could use if you deem it's appropriate to use in that particular scenario. And obviously, we need to look at the training records to see if the staff have been trained. And again, we're touching upon this when it comes to COP4, or I'll be touching on how do we look at this training records also. The next new objective element, and by new I mean this is a new objective element in the standard per se. We earlier had quality assurance programs only for ICU and surgical services. Now emergency is an addition to this list. And again, the interpretation is quite clear. It actually says what are the things that need to be in place. I mean, it's quite prescriptive in that way, if I may use. Again, what are the assessment checkpoints? We need to be looking at what is the documentation of the quality assurance program. We also need to be looking at what are the key performance indicators. I mean, in a way, a small organization can use the indicators. We have about 70 odd indicators now. Some of them do pertain to emergency. The same indicators can be used, or there could be a fresh set of indicators. Please note, it is left to the organization as to what those indicators are going to be. But again, what we need to ascertain is, based on these indicators, what improvements have been carried out. The loop has to be closed. It has to be taken to a logical conclusion. There's just no point if only the data is captured with no action being taken. I'm sure all of you will agree with me that the key aspect of this is going to be as to how improvements have been carried out, and that has to be a very contentious area on which I think we can spend an entire webinar but still not have a consensus at the end of it. But I think life has been made slightly easy because there's a very exhaustive interpretation. And obviously, I'll not be reading the interpretation. You all have the standards, so I presume that you will go through it. There's a very exhaustive interpretation. And again, it says very clearly as to what are the things which need to be done if the patient is found dead on arrival, and again, if the patient dies on arrival. So there's a very exhaustive interpretation. Moving to our focus, it is assessment checkpoint. What should we be assessing when it comes to assessing this particular objective element? The obvious thing is the documentation. So what has been done, because documentation with respect to patient found death on arrival and death on arrival. Please note all the points that are there in the interpretation have to be covered as a part of the documentation. And again, if you look at the interpretation, it says that a logbook has to be maintained. So we need to see as to what is there, whether a logbook has been maintained, and has to review the logbook to see as to what is recorded. And please note, the emphasis is on this phrase called as where applicable. Let us be very clear. Again, this is a very contentious issue, a very debatable issue. Organizations may have different viewpoints as to how they will look at it. But the keyword here is where applicable. We need to look at police intimation, the medical legal case registration, so on and so forth. Again, many times we may not be actually be able to have the scenario during assessment. And obviously, during such scenarios, the what if scenario is a good tool to find out adherence to the objective element. And again, if you look at the requirement of the objective element, it's also there that the body has to be stored in a proper manner. So we used to visit mortuary. Now there's one more reason as to why we may have to look at the mortuary also to ascertain if the temperature and infection control measures are in place when we come to these aspects. So that's with respect to COP3. Sorry, COP2. Now moving on to COP3, which is an extension of what we have in terms of COP2, which is from emergency we want to ambulance services. Again, no major changes as such, but again, some changes in the syntax. If you look at it, there has been more added clarity with respect to what are the statutory requirements. We've obviously been checking for it. And again, if you look the word, as I said, ACLS, BLS has been replaced. We no longer use those words. So this particular phrase has been removed. Again, if you look at this, the word BLS has been sort of replaced with basic cardiopulmonary resuscitation, because that's what the focus has been in the fourth edition. It has a proper communication system. But here again, the fourth edition now brings in more clarity as to what is the purpose of this communication system. Why should we have this communication system? What is the expectation that the organization, what is the expectation that we as assessors will be looking at it when it comes to this communication system? And again, the assessment checkpoints would be, because if you look at closely, this whole thing should see right from the organization, how the call is received till the patient is received in the organization. So we could check the organization process for receiving a call for patient transport and see if the later on time frame has been adhered to. And obviously, we can always interview the staff to find out if there is clarity in their role and they are aware as to what needs to be done. Sorry. The next objective element deals with, again, as to it's not just sufficient if the ambulance goes there and gets the patient. The expectation is when the ambulance goes to get the patient to the organization, some care is provided to the patient, and that is what is completing the loop in a way. So this again, this new objective element brings about, talks about this aspect, where it will speak about what needs to be done when the patient is shifted to the organization. And again, this is a very exhaustive interpretation. You will notice that it runs into almost 2 slides into this presentation. But again, what are the assessment checkpoints? As you will make out, again, this is going to be very difficult. We will be fortunate if an actual transfer happens when we are there, but it's more likely that we will not be able to actually assess this when the transfer is going to happen. So again, a good way is to again try and interview staff and find out as to what do they do, and more importantly, we could ask those things as to, rather than asking them pointed questions, we could just ask them to give a description of what they did the last time they transferred a patient from home to the emergency department, or maybe from another hospital to this emergency department. And again, the expectation, again, please note this is not mandatory. The expectation is most organizations tend to document the care that has been provided, even though this care may have been provided in the, say, in the ambulance. So if you could always check in the medical records to see as to what is the care, and that is the reason as to why we have put this word where possible, we could try and ascertain as to what's being done. Now moving on to COP4. Now COP4 is nothing new. We all know this was in FMS. Now this has been moved to COP4. We're not spending much time, but the only thing I want to emphasize is, please note now the disaster management plan has to incorporate even managing clinical activities during the event, because this was not there earlier. In fact, if you look at the NDMA guidelines, I'm sure all of us have visited the NDMA website. There are exhaustive guidelines for the various disasters. In fact, the most recent one is on hospital safety. For those of you who haven't visited the NDMA website, the first guideline that you see now is on hospital safety. And in fact, in that guideline, there's actually the NDMA guidelines on the triage, the 3 criteria. Nothing new, it's essentially the same old triage criteria, but there's an official stamp to it in terms of how a disaster triage could be done. COP5 is essentially now, from this point onwards, we notice that every standard has moved up one place. It's been given a promotion, if I may use that word. So this deals with CPR, and again, by now you should have understood that the key change is we no longer use the word BLS and ACLS. But again, this part is being emphasized. The whole idea of this is it should be initiated as soon as a condition requiring CPR is identified. And again, this is going to be very tricky to assess, because yes, if there is a code blue or if there is a CPR activity going on, we can actually see it. But again, by the time we reach that place, even though there's a code blue or say a CPR going on, the initial care would already have been provided. So we may not be able to actually see it. So it becomes imperative again that we use the what if scenario to try and find out as to how staff go about. Yeah, this is what I was trying to say earlier when it comes to COP2. It is no longer mandatory, and we as assessors should not be insisting that there should be a formal certificate of, say, a BLS training or an ACLS training, although we don't use this word BLS and ACLS. Now, essentially, what is important is the staff should be trained and the training should be effective. Now, the trainer, the hope is that the trainer would be a certified person, he or she would be a competent person to provide this training. And this is where I was saying when we look at this, we need to again look at evidence of training, including competency of the trainer, what are the training content, and obviously most hospitals will maintain a training record. This is what we need to see. But we should not stop at that. For me, a more important aspect is we need to find out training effectiveness. And obviously, we need to go beyond the so-called pre-test and post-test. The reason why I'm saying this so-called is all of us know. I mean, it's a good tool, but not necessarily the only tool, because for me, it only gives me at best the short-term memory has been checked, but not necessarily the long-term. So we really want to see what's the long-term effectiveness of all this training. It would be a good idea to do them various scenarios and interviews, which is what I think most of us do. So there's nothing new in this, but I'm emphasizing that we could use this methodology. And again, this was there the earlier standard, but please note, now it is very clear as to what are the minimum things that are recorded. This was not there earlier, so please note this fourth edition has got minimum requirements that need to be captured. And again, when we assess, we should ensure that all these points are used, they are captured in the CPR record. Similarly, for the next objective element, notice it's very similar. The analysis part was there earlier. Now it is said very clearly as to what are the key points, what are the things which need to be covered in this analysis. So again, in a way, as assessors, our job is relatively more easier. We need to check for all these points and ensure that at a minimum, again I'm emphasizing, it's at a minimum that these points are there. And hopefully this will bring in more objectivity and a more uniformity in the way we have been assessing this particular objective element. Because otherwise, sky is the limit, as they say. Each one of us was asking for our own interpretation of what we felt should be there in the analysis. So let me again re-emphasize, this is the minimum aspect, the minimum point that should be there in analysis. There's more than that. It is fantastic. Please do not forget this line. Also monitor the outcomes. So even that has to be seen when it comes to the analysis. The outcomes of CPR have to be checked for. The next standard deals with, again, not a new standard per se, but there's one small clarity. Again, there was some discussion on this in the WhatsApp group also in terms of assignment of patient care. Earlier thing was self-explanatory. In the fourth edition, there is more clarity as to how this assignment has to be done. And again, what could we be doing? We could obviously ascertain the nurse-patient ratio. But again, I would go a step forward and actually interview the nursing in charge or section in charge and try and find out as to what is their basis, as to how they have gone about. Because it's a bit tricky. We say that it's 1:1, 1:2 in the ICU, 1:4, 1:6. Medical college hospital, private hospital, and whatnot. We can confuse it with a lot of jargon to make matters complicated. Certain states have their own requirements. But in addition to looking at regulatory, I would say it's also a good practice to look at from a practical point of view, because by practical, I mean what is the occupancy factor, what's happening, what is the criticality of the patients, or do we find critical patients being kept? Many a times there is a system where earlier thing you could say was acuity based. In fact, there are international practices wherein such patients are kept right in front of the nursing counter in a way that reduces the requirement of nurses, so on and so forth. There are various practical ways also in which we need to ensure that patient care and patient safety does not suffer, and that's the key thing that we must be looking for in this particular objective element. The next one is COP 7, and again, to emphasize, it is on various procedures, not necessarily one procedure. And again, there is more clarity. I think this is now completing the loop. The registration used to start with a unique hospital ID being generated. Now it is very, very clear. The patient shall be identified with at least 2 identifiers. One of which shall be the unique hospital ID. In addition, where applicable, the organization also use a pre-procedure checklist. And again, here again, I think it's a straightforward. We need to look at the document. We need to see as to what is happening. Again, in this particular objective element, there is a small change in the interpretation, straightforward interpretation. I don't think there is, I think most of us have been doing this, checking for these screening assessments. Again, if there's a procedure which is going on, when the assessment is going on, fine. Otherwise, we always have a what if. I know that you're all getting what if, and you will say, what if this webinar gets over? What if I quit the webinar right now? Hold on, don't get such thoughts. We will continue for some more time. So don't do the what if scenario and say that what if I continue to see this recorded presentation and not listen to what is going to happen here, because I don't see the person, there is only sound and no lighting. So lightning will come later, hopefully that's how it is. But anyway, coming back to the discussion, let's continue doing this as to how we go about. Again, nothing new is already there in the third edition, but again, please note the minimum time frame has now been specified. The standards are very clear that the monitoring shall be done for at least 2 hours. The parameters, the minimum parameters for monitoring were already there. In addition, the time frame for monitoring has been specified. COP8 deals with blood transfusion, and interesting, a lot of discussion on this happened on the WhatsApp, especially with respect to this particular objective element, which is essentially informed consent is obtained for donation and transfusion of blood and blood compounds. The whole discussion was revolved around this particular point. And let me read it out aloud. And I'm doing this because I noticed there's been a huge discussion on this. The same consent may be valid for multiple transfusions of blood, oblique, blood components in a given admission inpatient, which has a defined validity period. And this is where we had a huge discussion. What is the validity period? Who should be setting this validity period? Again, the standard is very clear. In my opinion, there is no ambiguity at all. The organization is free to set whatever validity period it deems fit. If it's 1 month, so be it. Because generally the whole idea is for this entire admission, the same consent is valid. Now, why are we having such a huge discussion? Because there isn't enough literature, if you ask me, on what is a good validity period. And I'll repeat this ad nauseum. In the Indian legal parlance, the whole consent is under what is called the corporate law. It's not covered in the Indian Penal Code. It's not, there is no separate act for this. So it is more to do with the corporate law, and that is how the whole basis of this validity comes. I've been trying to do my own research, and I haven't actually found a very solid ground which says that this is the defined validity period. So at this point of time, I think to be fair to the organization, let us go by what they have said. But my only suggestion is, let us ask the organization, if they're going for more than 1 month or say, we should really ask them as to what basis, because the whole idea is when an organization documents a particular validity period, there has to be some evidence, some scientific evidence behind as to why they have put it as 1 month. It should not be an arbitrary figure of say 1 month or 1 week. So let's try and understand as to what their perspective is. And as long as they are sticking to it, I don't think we should be putting a non-conformity that they have given a validity period which is more than the NABH prescribed. And let me say NABH has not prescribed any minimum period. So what do we need to look for? Obviously, we need to look for the consent. We need to see this validity period is included in the consent form. See, this is going to be a tricky issue because organizations may be having their own consent forms. Now, what we need to look for is, does it include the validity period? Because this cannot just remain on paper. And by that, let me elaborate. The organization has a document which says that the validity period is 1 month, let us say, or for 15 days. But nowhere in the consent form is this documented. Nowhere is the patient made aware that when he or she is signing this consent form, this consent is valid for 15 days. That is definitely not acceptable. The patient should know as to what is the duration, the validity, the consent is valid, and that is where I think we need to be very, very clear. The consent forms need to have it. Yes, organizations may take their sweet time in putting in new form, so they could handwrite it. They could write it at the bottom. And how do we verify it? For me, the best proof is if I speak to the patient and the patient tells me that, look, I have been told that this consent is for 15 days, fair enough, even though it may not be, the organization may not have had the opportunity to modify the consent form. If the patient gives me this information, I would accept it. And I think that's what we should all be looking at. And again, we can look at the case sheets for this consent form. So I hope I have not added to the confusion. I hope that I have got some clarity on this particular aspect. The next one was again a modification of what was there earlier. Now it says very clearly, at the first instance, we would expect that a written consent is taken. After that, we don't expect them to be taking multiple consents. Every time they come, they give a sort of endorsement that is sufficient. Interestingly, please note, in legal parlance, verbal endorsement is fine. But what is the problem with verbal endorsement? Why is it that we all start insisting on having a documentation? It's for the simple reason that there is no proof. It is my word against your word. So essentially, to avoid these sort of problems, we tend to go into documented consent, we tend to go into endorsements. Now, how should an endorsement be taken? The organization is free to do it in any way. They can keep writing on the same consent form on the back side, they can put a tabular format, delete it, and just write the date and the patient signs. That's fair enough. There's no problem with that. But again, one key aspect I want all of us to look for is when such consent forms are taken, the complications of multiple transfusions have to be told very clearly. Please note, there is a subtle difference between single transfusions and multiple transfusions because the risk of various complications goes up. There are certain complications which start kicking in only when there are multiple transfusions. So that is an important aspect which needs to be adhered to when it comes to these particular consent forms. So moving on to the next standard, which deals with the ICU high dependency units. Again, this is an absolutely new objective element. If you ask me, a much needed objective element which actually speaks about patient communication. And again, there's a very elaborate interpretation which says as to how it has to be done, how frequently, when should it be done, so on and so forth. But again, how are we going to assess it? Obviously, we can look for the documentation to see what has happened, and this can be done by speaking both to the patient and also to the doctors. I would say again, there will obviously be relatives of the patients to whom counseling has been provided. My only request to fellow assessors is, it is possible that relative A, for example, let us say the son has been counseled about the full thing, not all the relatives may have been counseled. So when we go for assessment, the son may not be there. It could be another relative. It could be the daughter who is there at that point of time. When we interview the daughter, she has absolutely no idea as to what has happened because the whole counseling has happened with the son. So let us put in that extra effort and try and find out from the organization's perspective as to who has to be counseled. Now it's again debatable as to how many you should counsel. Let's be practical. It's not possible to counsel every relative in everything that is going on. So usually many organizations have put in a practice as to who should be informed. They take this thing at the time of admission, or take it at some point in the stay, and that particular person is kept aware of all the developments. So we need to ascertain by speaking to this person whether he or she is aware of all the happenings that are going on within the ICU. The next thing here is dealing with vulnerable patients. Again, not much of a change. The only thing is certain guidelines. Again, please note, I emphasize the word here is could. It is not should. It is could. So that means, what it necessarily means is that organization is free to put whatsoever they want to include under vulnerable patients. But this is just a good practice. So please do not raise a non-conformity stating that on review of the documentation, it is noted that comatose patients have not been included under vulnerable patients. Please don't put as a non-conformity. However, please bring it to the organization's notice. Look, it's a good practice to include these patients, the comatose patients, the sedation, so on and so forth. But kindly do not put a non-conformity because at the end of the day, it's a good practice which organizations need to adhere to. The next standard deals with pediatric services. Again, no major change per se, but essentially if you look, there's been some clarity brought in terms to how should the scope be displayed when it comes to the scope of its pediatric services, what are the things which need to be displayed. Similarly, what the object element, it was psychosocial earlier on, that has been replaced with developmental. Again, growth and developmental go hand in hand. So in a way, again, we need to look at this whether it's happening or not. Interesting objective element, if you ask me. Now you may wonder as to what is so interesting, what is Dr. Anand seeing which none of us are able to see. Now, I don't know what your experience has been, but when I look at this objective element, in many places, the only documentation that I have seen is 14. But let us understand the keyword is prevent. It is prevent child or neonate abduction and abuse. See, the focus should be on prevention, and that is the reason as to why I think the interpretation now has this highlighted. It is the new thing is added. The key aspect should be this. In the rare scenario or in that central event that a child actually gets abducted, then also there should be a process as to how the organization is going to respond. Please note, having only the latter with no documentation of the former is not acceptable. The former also has to be documented. So how do we assess? Again, we'll obviously look at the documentation, documented procedures. We'll look at the training records for this. We could always look at this. And again, we could do the what if. We don't. It's a bit tricky. So when it comes to mock scenario, it's a bit tricky as to how many mock scenarios, what will you do? Because nowadays, we think that codes are known only to internal people, but patients are becoming smarter. People are realizing what these codes mean. If you announce a code ping, it may create an alarming scenario. So we need to be a bit sensitive to the organization. That's the only thing that I'm saying when it comes to announcing various codes. Because it should not happen that in the span of 10 minutes, 3 codes are raised. And this actually has happened during assessment. So we need to be careful. We need to be a bit more circumspect when we raise codes. And again, for a code like code ping, we not take the help of other SSLs in our team because various processes will kick in at various parts of the hospital, not necessarily in one place. And that is the reason as to why we may need to take the support of all. Sorry. And again, in the CCTV, it's important to see. Organization said we have a CCTV, but there's no CCTV near the nursery. So we need to actually see if the CCTV is actually placed as to where it is supposed to, and if the CCTV is actually on. Because in case most shops have a CCTV which is only a dummy, there's no wire connected. I hope that is not the scenario. Anyway, moving on, I hope you are not gone into this. I hope that you are not gone into moderate sedation because it's almost halfway down. I mean, we are almost 2/3 down with this session. Essentially, COP 13 deals with moderate sedation, and again, this has now brought in more clarity as to what needs to be done. It says very clearly as to who will take the consent, and what is important is the family needs to give a separate consent for moderate sedation. However, the form can remain the same. Here again, I think in SSR conclave, especially in the Kochi SSR conclave, there is a huge debate on this particular aspect. Again, I'm not going on to this. The standard is made very clear as to who can give it. Similarly, there is a word added in the objective element in terms of G. It is not just recovery, but also from the observation area. There is one small subtle change in the interpretation of H. I don't know how many of you actually noticed it. Earlier, it was in the hospital. Now it's in the area. So please, again, it may be tricky for an anesthesiologist to be placed right the sedation is going on. So let's give some leeway, and again let us look at what the intent of this is. The intent is again within, let's say, within a minute or so, if things go on, the anesthesiologist should be able to come. I think that's what we should be looking at rather than going by the word meaning and start putting non-conformity stating that anesthesiologist is not there in the area. I think that's something that we need to be careful about. After sedation, obviously, it's anesthesia, and again, if you ask me, I think there's a certain objective element, and which I used to actually face a lot of flack because I used to do, let's say, a lot of non-conformities. I'll come to that part later. But again, what is added here is it says very clearly that the anesthesiologist would review the medication, and this was the tricky aspect of the third edition because specified as to what necessarily had to be there in terms of anesthesia plan is no longer there. So please note, type of anesthesia is now accepted. If you just write the type of anesthesia, that is sufficient. If you just mention the pre-medication, that is sufficient. It is not necessary to have this full aspect in the anesthesia plan. So now the next thing is about surgical procedures. Again, not much of a change. The only thing is a line has been added in interpretation, and this is essentially to keep in mind that consents will be taken 2 or 3 days prior to the operation. The consent will be taken a week prior to the operation. Again, there is no set time limit before which it is taken. But as I said earlier, there is nothing which I am aware of which says that a consent is valid for X number of days. So you can take the consent in the OP consultation. Let's say the patient is admitted a week later. But between the OP consultation and the day before the surgery, the patient's status may have been changed. So some of the clinical risks may have changed based on certain reports that are now available. So what is essential is the new risks, or if there is a change in the expected outcomes, that has to be explained to the patient. And the only way we can assess it is by interviewing the patient. That's how we will be assessing this particular objective element. So again, as I said, we'll be using a lot of what if scenario. The actual new, the only new standard in COP essentially deals with organ transplantation. Again, you will notice that each one of these standards has a very elaborate interpretation. Those of you who haven't visited, please visit this website, National Organ and Tissue Transplantation Organization, NOTTO. If I'm not mistaken, it is NOTTO, NOTTO.nic.in. It's got a lot of information. It is on the Transplantation of Human Organs Act, the TOA Act, all those details are there. There's a NOTTO, there's a HOTTO, and a SOTTO. It's a rhyme. Maybe children would love to sing this rhyme. There was no NOTTO, then there was a HOTTO, and then there was a SOTTO. Essentially, other than NOTTO, to the best of my knowledge, at least maybe just one brought to the KM, one in KM is there for the Western zone. Is sort of active. I'm not sure of the rest. Please note, each of the states have their regional. For example, for the southern states, it's in Chennai. For the western states and the part of central India, it's in Mumbai. For the northern parts, the NOTTO, the National Delivery Itself Act. For the eastern part, there is in Kolkata. For the Jammu and Kashmir, Himachal, there is in PJ, Chandigarh. Then there is one in Guwahati, so on and so forth. So you can go to the website, all those details are there. But coming back to what is our focus on the assessment checkpoint, please note that the HCO needs to comply with the legal requirements. And again, in the 4th edition, it's straightforward for us. The organization has just been undertaking that they're adhering to it. But essentially, please look that on the NOTTO website, there are a list of hospitals which are approved. And if you go to the NOTTO website, it will show you which hospital is approved for what sort of a transplant, so on and so forth. You obviously look for all these documents when it comes to organ transplantation. The other thing is the coming from the authorization committee. And again, there are formats. If you go to the NOTTO website, you can download form. There's form 1 to form 21. Form 1, 2, 3 essentially deals with various types of consent forms that need to be taken. So there is a format on which consent has to be taken. So we need to ensure that these consents are taken in that format. And again, the reports have to be submitted. It specifies if there is being done or not. The next one again deals with the organ transplant program. Again, very elaborate interpretation is there. What are the assessment checkpoints? Essentially, we're looking for documented policy and procedure, availability of same in the places where it is done, and obviously the awareness whether the doctors, nurses, and the coordinators are aware of what is the procedure needs to be followed. The key thing of any organ transplantation is counseling, and no wonder that we have a separate objective element deals with this. Again, there is a very elaborate explanation of what needs to be done. And again, what about policies and procedures? The availability of trained. Again, the keyword is we need to have competent counselors. Please don't start insisting that a particular qualification is required. The key thing is trained. And again, if you notice on the NOTTO website, there are people who are empaneled to do all that. So if NOTTO is empaneled, we should not be objecting to those aspects. And if we can always interview a transplant recipient during our assessments, but again, it's a bit tricky because they're usually immunocompromised, so it may not be a good idea to go party and start interviewing them. Maybe we could interview the relative of the patient to get a better clarity. Again, review of various forms, formats, so on and so forth. The last one, again, this is one thing. ABNs would apply if the organization is doing an organ transplant. However, objective element D will apply irrespective of whether the organization is doing organ transplantation or not, because this deals with organ donation. This deals with creating awareness about organ donation. And again, we'll be looking at the various material that is used by the organization regarding how they're going about doing it, doing the organ donation awareness. That's a good thing. And again, look at the NOTTO website. There is material which can freely be downloaded, which can be used for this purpose. Restraint, and restraint. I think on the lighter side, I think if I may take names, I rather not take names. There are a few people in the NABH QA group who will keep telling other fellow members to restrain themselves. And here the restraint is they're asking to restrain from posting non-academic posts in the academic group, because it therefore very clearly those posts should go into the virtual post. Here I am not speaking about that restraint. Obviously, this is about physical and or chemical restraint. Again, there was some discussion of this particular aspect. Just one, please note the wording of objective element C has been changed. Earlier it was this include documentation of reasons for restraints. It's now modified as the reasons for restraints are documented. And again, brought in. Again, please note, from a standard perspective, taking consent for restraint is not necessary. Again, the standard does not specify a minimum duration as to which you will look at. It does not specify that a restraint order is valid for, say, 4 hours, 6 hours, 8 hours, 12 hours, 24 hours. It is left to the organization. And again, it is left to good practice. Now, if you look at what, say, let's say, the JTI says, I mean, in the new edition, the earlier edition, it used to be said, for every 4 hours, each thing, and you need to keep reviewing it every 4 hours, and then if it exceeds beyond 24 hours, then a fresh order has to be given. For, say, a patient who is between 9 and 17 years of age, it was about 8 hours, or sorry, it was 2 hours. For a child below 8 years, it was every hour. So there are various perspectives, there are various good practices, but we as assessors shall not insist on a practice and state that this is the only practice. We need to understand as to what is the logic, how they have gone about doing it, and accordingly go about doing it, because the standard is very clear. These patients have been monitored more frequently. So essentially, we look at the medical record for these reasons. We interview the patient, interview the relative. We will also speak to the staff to understand as whether they have been trained, whether they are aware of the policy and procedure. Moving on to another pain area, I always say COP 18 is pain management. It is a new objective element which deals with pain alleviation measures or medications are initiated and titrated according to patient need and response. Again, there is a very elaborate interpretation. Essentially, this is by review of medical records and by interview, I would say, of the duty doctors, resident doctors, or consultants. Again, let me clarify, this standard applies to all patients, that is, patients coming to both OP and IP. Because it was very clear when this objective element was put, and it continues to be so even in the 4th edition, all includes all patients coming to the hospital, and that's essentially because pain is a fixed vital sign. And recently, a friend of mine was telling us how it has helped him in his practice. Once he started putting in this pain scale, he has now a pain scale for every patient in his screens. He has picked up actually new diagnosis or new consultation, cross consultation have to be given, because patient, I think, for example, the patient is coming to me with breathlessness. I don't bother to ask about pain, because pain also has osteoarthritis. I don't give cross referred to position. Overall, it leads to a better quality of life to the patient, and that's the reason as to why it has to be screened for all patients. Again, there is one new sentence, iron interpretation provides primary measures for immediate pain relief, because again, the 4th edition is trying to make this loop close and put in effectiveness measures. And again, it's the review of medical records or the interview of duty doctors or resident doctors. COP 19 is to rehabilitate. Again, not much of a change. The only thing is, it says very clearly now relevant functional assessments here. So please note, depending on the rehabilitation, depending on the condition, there are plenty of functional assessments here. It's not that there is one functional assessment. So we need to look at which functional assessment scale has been used. Again, that is done by review of medical records. The last standard which I will be discussing. Yes, you can all pause, and there isn't much left here. Again, not a new objective element. Only thing that can add an interpretation is the committee is registered with the appropriate authority. Now, for those of you who are not aware, again, the DCGI has now made mandatory that the ethics committee has to register with DCGI. If you go to the DCGI website, again, this information is there. So organizations which have an ethics committee have to register themselves. Now, please note this ethics committee from a research perspective. Please note this is from a research perspective. Organization may have an ethics committee for a different form, taking actually ethical, that's a different aspect that doesn't come under this. So I think over the past 50, 45 to 48 minutes, I give you a broad overview of what essentially are the various changes that have come in. The focus of this webinar was essentially to bring in uniformity in assessment practices. So hopefully we have brought given you some clarity with respect to how we will be assessing the new objective elements. That you will have a lot of queries. So let's take some questions and answers. And I will try and answer it to the best of my ability and my knowledge, but please don't assume that I will have an answer for everything. I think now I'll request NABH Secretariat to make the session open for Q&A.
Okay, thank you, Dr. Anand, for a brief and enlightening session on COP. Now we will take one by one question which are raised, and Dr. Anand will try to address all the queries that is being asked. Sir, can you hear me?
I can hear you.
Yeah, sir, the first
Loud and
question,
clear.
yeah, the first question I am taking from Dr. Puneet Agrawal. His question is, should the SCO have a defined list of drugs for chemical restraint?
From a standard perspective, the straightforward answer is no. It is up to the organization because it's a bit tricky. There are standard lists which are available as to what is, because if you look at international literature, they don't use the word chemical restraint. If you look, it is called as behavioral restraint and medical oblique surgical restraint. So I think there are various perspectives, but a straightforward answer, no. The organization has, it's a good practice. If they don't have, no problem.
Okay, thank you, Dr. Anand. Now the second question is from Dr. Sheetal Dikshit. Dr. Sheetal Dikshit, I am going to give you a chance. You can speak and directly ask the question to Dr. Anand. Now you can raise your question, Dr. Sheetal. Can you hear me?
Yes, I can. Can you hear me?
Yeah, definitely.
Yes,
Hello?
Yeah.
Yeah. Sir, I wanted to ask.
Hello.
Sheetal, unfortunately, I can't hear.
Yeah, sorry.
Hello, doctor.
Can you hear me now?
Yeah. Tell me.
Yes.
Yeah, so the thing is, this dead on arrival and dead in emergency are two very varied perspectives. Now, you have, what is that? Should they have a policy on dead on arrival? Policy is fine, but dead in emergency room, I think it could be very tricky here, you know, for them to have a policy on how do I check this, and this is a very dangerous area that we are treading into. So what is the intent of this? I'm not very clear.
Okay, thank you, Dr. Sheetal.
I will answer from an assessment perspective only because that is what I will limit myself to. You are right. I mean, it's a bit difficult. It's a gray area. But I think from an assessment perspective, what we need to look for is, because the standard, as I said, has already laid down a very elaborate interpretation of what is to be covered. From a documentation perspective, it is very clearly as to what needs to be documented at each one of those. So we need to be limiting ourselves to what has been documented. But yes, I do take your point, your concern that it's a bit tricky. Organizations will find it tricky. So I would still say give them a long length of rope to before we start putting non-conformity.
Hello.
Hello.
Yeah, sir. I'm taking the next
Hello.
question. Yeah, hello. Sir, can you hear me?
Yes.
Yeah. Sir,
I can hear you loud and clear.
Yeah, sir. Next question is from Dr. Naveen Chug. Dr. Naveen Chug, I am giving you a chance to ask the question directly to Dr. Anand. You can now raise your question. Dr. Naveen, can you hear me? Dr. Naveen? Never mind. Sir, the next question, Dr. Naveen tried to say the trials for one bedded emergency room, example in oncology specialty hospital, having 5-6 patients in a month in ER.
Yeah, from an assessment point of view, they don't require a trial at all, you ask me. Again, I want to emphasize, let's look at the practical point of view. If for example, I will speak further, what is the point of having a trial in ophthalmology hospital? That cannot be applicable. So I think we need to understand from the perspective of where applicable it is looked at. There are patients only coming in, say 6 patients in a span of 30 days. There's a question of triage. You can do whatever you want all the time in this, on this planet Earth to do whatever you want. The idea for triage is when you've got a series of patients coming in, when you've got a busy emergency to put in place. So if the assessor is convinced, and again, I think this is where we as assessors need to start looking beyond the stated text. If the assessor is convinced that there is a valid reason as to why they are not doing this, I think the benefit of doubt should go to the organization rather than stating that although the organization receives only 6 patients in a span of 30 days and has got a one-bedded emergency, triage is not being done. I think that is stretching a bit too much.
Okay, sir, now the next question is from Mrs. Antonia P. She wants to know how safe is to take a consent by a nurse under supervision in an Indian legal framework.
I presume this is consent for moderate sedation. I presume that is how it is. If you look at the standards of consent, it is very clear. The consent has to be taken by the person who is performing the procedure. So, going by that, the nurse should not be taking the consent. If you ask me, the person who is performing the procedure should be doing it. In sedation, it says doctor or nurse under supervision of a doctor. Then again, in moderate sedation, the interpretation does not allow a nurse to be only doing it directly. The nurse will again do it under the supervision of a doctor. So, in my opinion, the onus is on the doctor to take the consent. However, another tricky aspect is this touch upon and again clearly elaborated upon. Nurses have witnessed that's again a gray area. My personal opinion is to the extent possible it should be avoided. Only where there is no alternative should the nurse be doing it. Because again, the common practice in most organizations is the doctor explains and the nurse takes the consent. Okay. I always have a counterpoint. If the doctor can spend 5 minutes explaining to the patient, what prevents the doctor from spending another 30 seconds and asking the patient to sign? It is like we do all the dirty work and you do the outsourcing to someone else. I don't think that is required. I don't think it's a good practice.
Okay, sir. Thank you very much. Sir, next question is from Dr. Rajiv Chaure. Is it required for SCO to have separate consent form for vulnerable patients?
I think I made it very clear. The standard does not ask for a separate consent for any vulnerable patient. It's not a standard requirement. Even for restraint, it is not asked for.
Okay, sir. And sir, another question from Charul Purani. Do we require separate consent for surfactant in neonates if relatives are not available for consent?
Wow, we see so many things on consent. I think there is something left for hearing also to deal with consent. Really, these are, I think, very specific, subject-specific questions because I understand is again, pardon my use, the knowledge of new methods, because it's a very, very niche area, very specific question. Based on my knowledge, surfactant is given to save the life of a child. So from that perspective, the relative is not there. And if it is a life-saving measure, the general thing is another doctor signs on behalf and there are two doctors from independently ascertain viewpoint and you go ahead with surfactant remains patient. That is from that very niche area. The other aspect of course, I'm not going into it because I'm putting it in PRA.
Okay, sir. Thank you very much. We are taking the next question from Sheetal Dikshit. Her question is that can we have trained nurses and technicians under supervision of anesthesiologist? Is this acceptable?
Because I have clarity in which setting. See, if it's on a setting of moderate sedation, standard is very clear. Technicians cannot administer.
Okay.
Okay. A nurse can administer. So, from a narrow perspective of sedation only, it is very clear that the nurse can administer under supervision of the doctor. It can be anyone. It can be a physiologist, it can be a pulmonologist, it can be a gastroenterologist. There's no problem with that. The standard has not said it has to only be a doctor. The standard is very clear. A technician will not administer. Yes, there are pros and cons, and that's what I said. In the coaches as a conference was a huge debate on this. But being as to how they are, and should not be now reinventing the standard, so stick to it and say very clearly, reiterate rather, the nurse can live under supervision, but not a technician.
Okay, sir. One more question from Mr. Harshad Joshi. Dead body received from other hospital or police for preservation in mortuary are put directly without any other record in the hospital except mortuary logbook. Is it accepted?
As long as there is a death certificate given from another hospital, there is no problem.
Okay.
If there is no death certificate and you cannot give a body without a death certificate or anything, but as long as there are documents accompanying the dead body, like quote unquote dead, okay, there is a document accompanying, I don't foresee any problem.
Okay, sir.
I would like to add one more thing, Dr. Anand. They should have an SOP for dealing with some bodies who have patients who have not died in the hospital, they should be detailed SOP. How to deal with different conditions. Now the police has brought a dead body, and what should be done? They are asking. There may be some chances, some other nearby hospitals or some other resource. They like to keep body in a particular hospital having a mortuary facility. So they should be clear that define.
Yeah, they can have a separate SOP for mortuary practices. Fair enough.
Yeah, yeah. And they should, in such cases, they must not any medical legal or any foul play. Yeah.
Sir, we are taking next question from.
But again, the assumption here is that the police has already cleared it and the body has only come for storage. Only in that limited scenario is what I clarified.
Yeah. Sir, the next question is from Dr. Rajesh Deepai. Dr. Rajesh Deepai, you can raise your question directly to Dr. Anand. Dr. Rajesh Deepai. Dr. Rajesh, can you hear us?
Yeah, sir. Yeah. Sir, my doubt was regarding the change of procedure. The COP 15C, which says that when the procedure is changed intra, we need to take a fresh consent that needs to be taken. So, is it to be done before you undertake that procedure, or maybe difficult to take like that? So later, post facto, can we do it rather? Take the consent.
Dr. Rajesh, I think again, we do not have an option. This is the classic Samira Kohli versus case. This is the case I think which is quoted always. And I'm sure that you know this case much better than I know. You know it in and out of this case. That's the basis. I think the legal stand is very clear. The judgment is very clear. You cannot do a procedure without consent. So if you have to change, unfortunately, and I'm emphasizing the word bold, highlighted, italicized, whatever you want to say it as, unfortunately, the legal stand is that you have to shut and come out, take a consent, and then do it separately. If you ask me, that may not be the right thing to do, but if you want to go on the right side of the law, always, you have no alternative but to do it that way. And it is exactly for this reason that many hospitals nowadays take consent for both. You take a consent for lab cholecystectomy and also for open cholecystectomy, because these are common scenarios. Your lab gets converted into open, you cannot come out and then go on, because even the Samira Kohli case, the consent was taken, but then the person, Samira Kohli, argued that the consent should have been taken for me and not for my mother. So in this case, to cut a long story short, we do not have an option but to, in a very unlikely scenario, close, stop doing what you are doing and then redo it.
Okay, thank you, sir. Sir, one more question I am taking from Dr. Uday Bhaskar Mishra. How an assessor will assess COP 1D?
The evidence-based medicine, I presume that is what it was. I am not an expert. I don't have my standards in front of me, but this is essentially as to what it is. Evidence-based practices link it. Mr. Sir knows, and we all know, this is essentially where we park deficiencies where we cannot put anywhere else. It's very, very difficult, because what is evidence-based medicine? If you go by definition, most organizations will have a non-conformity in COP 1D. Because there are practices which may not necessarily be 100% evidence-based. So it's a bit tricky. I understand sir's concerns, but from an assessor, what we need to look for is, I would say, gross violations of evidence-based medicine rather than looking at some nitty-gritty aspects. And I would also say that, let us face facts, we tend to use this particular objective element to park deficiencies which we cannot fit anywhere else.
Okay, sir. Thank you. Dr. Vandana, can you hear us? You can ask your question directly to Dr. Anand. Hello, Dr. Vandana? Dr. Vandana?
The mobile link is down.
I think you cannot hear us. Okay, no problem. I'm taking the next question, sir.
Please.
Sir, the next question is from Dr.
The next question?
Shankar Sen Gupta. He wants to ask how to see appropriateness of handover documents.
That was in AAC, if I'm not mistaken, but still, it's not necessarily in COP. Again, it's very, very difficult to come up with a methodology which will tell you that this is appropriate and that is not appropriate. I can only speak for myself. What I would look for is, I will look at the condition of the patient and then see as to what the documentation states. The whole idea of the handover is when I speak to the next person, because there is a duty doctor who will be there at that point of time, who will be nurse at that point of time, he should be able to explain to me effectively as to what has happened in the previous year. If they are able to tell that to me, I would consider that as appropriate. But again, I would emphasize this is my viewpoint, which may not necessarily be accepted by all. But this is how I would look at this particular objective element.
Okay, sir. I think we have done almost every questions which has been asked here. So whatever question are being more raised, they can contact us at helpdesk@nabh.co and we will revert back to them. Thank you for the enlightening session, and I hand over to Dr. Kalra.
Thank you. I need to say thank you also. Just wait for one moment.
Yeah.
Essentially, I think I need to thank fellow members of the SSR Management Committee, Dr. Aarti, Dr. Prashant, Dr. Christopher, Dr. Vinay Kapoor. I think it's been fantastic because this the whole idea was initiated during a meeting and we are taking to multiple conclusions. I need to specially thank Dr. Vimal Kumar for the simple reason that he was very proactive in the WhatsApp group. He actually made life easy. He had linked the question paper to me, sir. There are certain questions, a lot of things need to be addressed. So I thank him for being proactive. And I thank you, Prashant, and Dr. Kalra for setting this whole thing up beautifully. So that's thank you now from my side. Over to you, Dr. Prashant.
Yeah.
Thank you, Dr. Anand, and thanks all the participants for participating and interacting very, very actively. Thank you. See you again in the next webinar. Very soon, date we will announce very soon. Thank you all, and thank you, Dr. again, Dr. Anand. Thank you.
Thank you, sir. You're welcome.
Okay, sir. Thank you. Now we are closing. Yeah.
Yes.